In this third and final video, we will be reviewing the laboratory tests that are most helpful for monitoring the severity and progression of disease, as well as helpful imaging studies. And finally, we will review the different stages of COVID-19 and factors that are associated with a poor prognosis or outcome. Laboratory findings are nonspecific. However, I have found three values to be particularly helpful in assessing the severity and prognosis of COVID-19. C-reactive protein, abbreviated CRP, is a measure of the degree of inflammation and is elevated in the majority of cases. A normal value is 0 to 5. More severe cases of COVID-19 have levels of 100 to 400, and the higher the CRP, the higher the likelihood of severe disease. D-dimer is a reflection of abnormal clotting and is elevated in severe cases. A normal value is less than 0.5. A value of 1 to 2.5 is associated with approximately a threefold increase in clot formation in the veins or arteries, and a value of greater than 2.5 is associated with a 6 to 7-fold increased risk of abnormal clotting. The lymphocyte count has been shown to be an important prognostic factor. When it is under 800 or 0.8 thousand, the risk of poor outcome increases. These studies were based on wild-type virus, as well as alpha and delta variants. As compared to these viral strains, Omicron stimulates lower levels of cytokines and is associated with the lower CRP levels and less severe depression in the lymphocyte count. Here are the values for the patient I presented. Note the marked elevation of CRP, D-dimer, and the decrease in lymphocyte count. On day 3, an IL-6 level was found to be markedly elevated at 48, normal being less than 0.9 picograms per ml. On day 6, we administered the IL-6 inhibitor tocilizumab. Note the improvement of these parameters following tocilizumab's administration. Here are two of our patients' Xrays on day 1 and day 2. You can see the marked increase in lung opacification or whiteout consistent with the development of acute respiratory distress syndrome or ARDS. Chest X-ray is abnormal in 60% of patients. Chest CT is a more sensitive, identifying abnormalities in 84% of cases. It should be emphasized the CT scan may identify abnormalities even in mild cases. In severe disease, 96% of the time, abnormalities are identified. Here are two examples of a ground glass appearance. On the left is in one lung field, the arrow. On the right is bilateral ground glass appearance. As discussed earlier, Omicron patients are more likely to have a normal chest X-ray and normal chest CT scan. This figure is from the WHO and shows the various levels of illness severity and potential outcome. Mild and moderate cases make up 80% of all cases, and mild cases rarely progress to death. Moderate disease and severe disease more commonly progress, and patients who are critical, like our patient, have a high chance of dying, 45 to 84%. Critically ill patients may develop septic shock with organ failure. This syndrome may be associated with high levels of cytokine, including interleukin-6, as seen in the case I presented. The average duration of hospitalization in the WHO experience was 12 days, 11 days for non-severe cases, and 13 days for severe cases. Mechanical ventilation was required in 38% of severe cases. Omicron patients are more likely to have mild to moderate disease and are less likely to require MICU care. To assess what stage each patient is in and to project whether or not the patient will worsen, it is important to understand the timing of the different stages of disease. Whenever possible, it is important to estimate the time of exposure and know what day symptoms began. The usual incubation period after exposure for Omicron and Delta is 2 to 3 days. During this period, the patient has no symptoms. Early on, the symptoms tend to be mild, and 40% do not progress. Even higher percentages of Omicron patients fail to progress. 2 to 3 days after the onset of symptoms, 40% of Delta patients experience shortness of breath, indicating moderate disease. As discussed earlier, Omicron patients are less likely to develop lower tract symptoms and are less frequently complain of shortness of breath. At 4 to 5 days, 15% of Delta cases progress to severe disease. These patients experience a decrease in oxygen saturation below 93% and require oxygen administration. At 7 to 10 days, 5% of Delta-infected patients become critically ill, require management in the MICU, and often require mechanical ventilation as described in our case. Because Omicron tends to remain in the upper respiratory tract, progression to severe and critical disease is less likely. As shown in this graph, the case fatality ratio varies from country to country, ranging from a low of 0.1% in South Korea to a high of 4.5% in Mexico. In the U.S., the case fatality rate is now 1.1%, the United Kingdom 0.9%, and Brazil 1.9%. Case fatality, or CF, is defined as the number of deaths per total number of patients with disease. These percentages may be overestimates because of mild disease is not always recognized, lowering the denominator. The case fatality rate will also be higher where care is limited, as exemplified by Mexico. To put these values in perspective, influenza's case fatality rate is 0.1%. Therefore, the case fatality rate of COVID-19 varies from 1 to 45 times higher than seasonal influenza. Mortality is related to sex, men having a higher mortality than women, as do patients with chronic illnesses, specifically hypertension, diabetes, cardiovascular disease, lung disease, and cancer, as shown in this table. Also, patients with obesity and sickle cell disease have worse outcomes. Mortality is also affected by age. Death is exceedingly rare below the age of 30 and begins to climb in those over the age of 60, being 4% for ages 60 to 70, 8% for ages 70 to 80, and 15 to 25% for those 80 and older. For patients infected with Omicron, nearly all deaths are in individuals over the age of 65, many who have had underlying diseases and or were receiving immunosuppressants. The mortality for patients hospitalized with Omicron infection in our hospital, University of Florida Shands, was comparable to the Delta variant. Hospital mortality for Omicron 7% versus 5% for Delta. Clinicians should not let down their guard when treating elderly Omicron-infected patients, understanding that in this population, the risk of death is high. In summary, lab findings in this disease are nonspecific. CRP and D-dimer are helpful for assessing severity of disease, and a low lymphocyte count is associated with a poor outcome. Omicron patients have lower CRPs and higher lymphocyte counts than Delta patients. Chest X-ray has a low sensitivity, chest CT scan being more sensitive, often showing ground glass opacification. A higher percentage of Omicron patients have a normal chest X-ray findings. 80% of the time, the disease is mild to moderate in severity, but the disease can progress to irreversible hypoxia and death. Disease progression is more rapid for those infected with the Delta variant and less likely in those infected with the Omicron variant. A higher mortality is seen in men, those 60 years of age or older, and those with underlying disease. In the elderly, the hospital mortality rate for Omicron is comparable to the Delta variant. Case fatality rates vary by country, ranging from 0.1 to 4.5%. COVID-19 being 1 to 45 times more deadly than influenza.